Good day, everybody. Can you all hear me well enough? And can you see my screen?
Yes, we can see you.
That's great. So thank you very much for inviting me to give this presentation. As was mentioned, I'm a health economist at a consultancy called Data for Decisions in the US, and a research associate at the Harvard Chan School of Public Health. And I will speak to you today about the economic evaluation of universal pediatric PCV. Now, before I say anything of substance, I would like to reiterate some disclosures. So first, I am receiving an honorarium for my presentation today from Pfizer. And I have also, in various commercial and academic capacities, performed research that's been funded by vaccine manufacturers such as Pfizer, Merck, GSK, Sanofi Pasteur, MSD, and also by the World Health Organization and by the Bill and Melinda Gates Foundation. Now, I don't know if, so let me now start. I don't know how many of you like movies, but for those of you who do, you probably know that Avengers Endgame came out worldwide this past weekend. I have an 11-year-old son, and so it was absolutely necessary for me to watch the movie with him. The thing about a movie is that when you watch a movie, you do not want anybody to tell you at the start of the movie how the movie will end. You want suspense. You want the outcome to unfold naturally as the movie progresses. Needless to say, my presentation today is not Avengers Endgame. It isn't a movie, and so suspense is not an important part of this presentation. Given that, I would like to start by sharing with you my absolute bottom line. I want to leave no ambiguity with respect to what my main point during my presentation is, and here is my main bottom line. The bottom line is as follows. If Malaysian society wants to make wise choices regarding universal pediatric PCV, it must not think only in terms of universal pediatric PCV's health-related outcomes. It has to go beyond thinking about the impact of vaccination on the health sector. It must also think about the impact of PCV vaccination on Malaysian society and the economy as a whole. So you must think not only in terms of the impact of vaccination on averting deaths, disability, and costs to the health payer. I'm not saying these impacts aren't important. They are important, but you must move beyond them. You must also think of the impact of pediatric vaccination on education, on productivity, the ability of children, parents, and the elderly to work, the impact of vaccination on financial risk protection, poverty reduction, and economic growth. So you should think of universal PCV vaccination as not just a health policy, it is a socio-economic development policy. I encourage you to try to think not only as doctors and health professionals or members of the health sector, but to try to think or to put yourself in the shoes of, to adopt the perspective of, the Ministry of Finance and the Cabinet of Malaysia. If you look at ministries of finance and the cabinet, their traditional core concerns usually do not immediately start with health. Their concerns are typically issues such as productivity, poverty reduction, financial risk protection, and economic growth. Now, they may mistakenly think of vaccines as somehow a competitor to those core concerns. That is, they might mistakenly believe that the more they spend on PCV vaccination, for example, the less they will be able to promote their core concerns. If they believe this, you need to impress upon them that this is a mistaken belief. You need to communicate to them that spending on PCV is a way of promoting the core concerns of ministries of finance and of cabinets. The spending on PCV is spending on poverty, on productivity promotion, on poverty reduction, on financial risk protection and economic growth. You need to communicate the broader socioeconomic value of universal pediatric PCV to the Ministry of Finance and to the cabinet, and hopefully communicating that broader socioeconomic value will facilitate its introduction into the national budget. I encourage you to try to show that the rate of return to expenditures on PCV, the rate of return that takes into consideration all these broad socioeconomic benefits, compares favorably with the rate of return to public expenditures outside the health sector. That, in sum, is my main message. If somehow, through my presentation, you lose the thread of my argument and it becomes unclear exactly what I'm saying, go back to this message, because ultimately this is the message I want to leave you with. So, how will I flesh out this message? Well, first I will start out by describing some relevant features of the Malaysian context. Second, I'll talk a little about what the economic evaluation of vaccines actually is. Third, why we need to do it. Fourth, who needs to do it. And fifth, what is value? In other words, if you're trying to measure how good the vaccine is, what counts as good? Here you'll see that there are two competing perspectives on this issue, the health payer's perspective and the societal perspective. I will be an advocate for the societal perspective. Sixth, I will discuss the broad socioeconomic benefits of vaccination in general and universal pediatric PCV in particular. And then lastly, I'll talk about the differences between a health payer's perspective and a limited societal perspective in the context of Malaysia versus what a full societal perspective would look like. So let me begin with the first item on the outline, relevant features of the Malaysian context. So if we look at the Malaysian context in general, if we take a bird's eye view, we look at all of Malaysia as opposed to just the health system, what we find is an economy that is very, very close to becoming a high-income nation. I think that it will pass the threshold for high-income status in, I think, about maybe 5 or 6 years, certainly less than a decade. And a key policy commitment of the Malaysian government, as stated in the 11th Malaysia Plan, is inclusive economic growth. This is a technical term that basically means economic growth that produces well-distributed benefits. In the Malaysian context, it usually means economic growth that produces material benefits for the bottom 40% of the income distribution. In the 11th Malaysian Plan, inclusive economic growth is to be promoted through investing in human capital, that is, in the education and health of children, and in promoting productivity throughout the entire population. It involves promoting female labor force participation and promoting social protection and social assistance, in part to facilitate human capital investments. One key message I'd like to transmit is that this is the main concern of ministries of finance and a major concern of the cabinet. I think it is very important to link the contribution that universal pediatric PCV can make to these explicitly stated goals of the Malaysian economy and government. If we look at the health sector more specifically, one thing we find, and this was made clear in the briefing packet that we received, the Ministry of Health and pediatricians in Malaysia strongly support PCV. But the Ministry of Finance and the Cabinet have still not given their approval. And this is an issue that will be resolved sometime during this calendar year, to the best of my understanding. So here you can see that the health sector strongly supports PCV, but those who have more traditional socioeconomic concerns are possibly still on the fence about this, which raises the importance of appealing to the broad socioeconomic benefits of universal PCV 13. A third feature of Malaysia is that it is an aging population. I think that the threshold for having an aging society will also be reached within the decade. And as part of having an aging population, you also experience growing burdens of chronic disease. A fourth issue that was made clear by the Arushothi et al. Article that was also in the briefing packet is that antimicrobial resistance in pneumococcal disease is a concern. So these are the relevant features of the Malaysian economy. I will invoke them as the presentation continues. So now let's proceed to economic evaluation proper. So my second question is, what is the economic evaluation of vaccination? And basically, what it is the attempt to measure the value for money represented by some vaccination program. It tries to answer the following question. For every dollar spent by the health payer, and therefore in a tax finance system, for every dollar that is ultimately spent by the taxpayer, how much does society get back for that dollar expenditure? So economic evaluation is basically, it poses a bang for the buck question. For each buck, how much bang do you get? Is the value for money sufficiently high that vaccination represents a good deal? So that is what economic evaluation is, simplified. Why should we do it? Well, basically we need to do it at the intersection of two constraints. First, we have limited resources, right? We don't have infinite amount of funds to spend. And second, there are many policy options that compete for these scarce resources. Some of these competing policy options are health policy options faced by the MOH, right? So the more you spend on PCV, the less the MOH will be able to spend on other vaccines. The less it'll be able to spend on non-vaccine health expenditures. Therefore, the MOH has to assess the relative value for money of PCV vaccination and all these other competing health priorities. Now, some of these these competing policy options exist outside the health sector. So if you take the perspective of the Ministry of Finance and the Cabinet, then if you introduce PCV into the national budget, then you will have less to spend on your non-health priorities. You'll have less to spend, for example, on school construction or investments in IT infrastructure. So when you have scarce resources and competing policy options, the rational thing to do is to look for the policy options that have the highest value for money, and you direct your funds there. If you allocate funds that way, you will be maximizing the value produced with your limited resources. Next, who needs to do economic evaluation of vaccines? Here we will focus on two actors, the Ministry of Health and the Ministry of Finance. So both of these actors fit the template from the previous slide of having a fixed budget and competing priorities. In the case of the Ministry of Health, it has a fixed budget set by the Ministry of Finance or the Cabinet, typically. Right? So that's where the fixed budget comes from. And it has to allocate it across different vaccines, PCV, flu, and also across non-vaccine health technologies, cancer care, smoking prevention, and so on. So given a fixed budget set by the Finance Ministry, If you introduce a new health technology into that budget, that means you're going to need to displace something that that budget is already funding. Or you have to forego introducing some other new health technology. So if you're faced with that choice, you better make sure that the value for money represented by the thing that you're going to introduce is at least as large and hopefully much larger than the value for money represented by whatever technology you're going to displace or what other new technology you're going to forego. The Ministry of Finance faces an analogous problem. In its case, it has a fixed budget, typically set by the legislature or the tax system. And it has to allocate that fixed budget across the various line ministries. The Ministry of Health has to be given its budget, but so does the Ministry of Education, Ministry of Transport, Ministry of Environment, and so on and so forth. And the more you give to one ministry, the less you'll have available to give to the other ministries. And so the Ministry of Finance is asking the question, if the Ministry of Health is asking for sufficient funds in the national budget to finance universal PCV for children, that means that less will have to go to the Ministry of Education, less will need to go to the Ministry of Transport and all the other ministries. Does the value for money represented by universal pediatric PCV exceed the value for money represented by investment in IT infrastructure or investment in schools? That's the question faced by the Ministry of Finance and the Cabinet. So next question, what is value? So if economic evaluation is the measurement of how much value you get per dollar of expenditure, well, so what's the menu of stuff that counts as value? What do you actually measure? Here, there are two competing perspectives. The first, the more familiar one I expect to this audience, is called the health payer's perspective. And within this perspective, value consists mainly of health benefits and cost savings to the payer. So the outcomes that measure within this perspective are averted deaths and disabilities, quality-adjusted life years or disability-adjusted life years, and averted direct medical costs. The competing answer is provided, the answer I will defend and hope to justify is the societal perspective. According to this perspective, all the things that matter within the health payer's perspective, they do matter. They're not irrelevant, but they're not the only things that matter. The downstream socioeconomic benefits of those health improvements also count. So you have to track the impact of vaccination on education, productivity, financial risk protection, consumption, leisure, savings, poverty reduction, socioeconomic equity, fiscal impacts, economic growth, and reduced socioeconomic burdens from population aging. So how would you actually implement both of these perspectives? Well, I provide a little bit of analytical detail here. First, let's take the health payer's perspective. As I said, within this health payer's perspective, only health and health payer cost savings count. Within this perspective, health is typically measured using QALYs or DALYs. So for those of you who are not familiar with QALYs or DALYs, this is roughly how it works. Say that you have a health technology that you introduce into the health system, and say that it extends life expectancy by 2 years. And let's also assume that for those 2 years, the quality of life on a 0 to 1 scale, where 0 is the quality of life of death, and 1 is the quality of life of perfect health, let's assume that for those 2 years, quality of life is 0.9. Then the QALY gain from that health technology is 2, the number of years, times 0.9, the quality of life. So the health benefit, the QALY benefit, is 1.8 QALYs. Within this perspective, the value for money measure is called the incremental cost effectiveness ratio. So let's assume that the cost to the Ministry of Health of this health program is $9,000 per person. Then the incremental cost effectiveness ratio is just the ratio of the cost to the QALY gain, right? So it's $9,000 divided by 1.8 QALYs. So you get an incremental cost effectiveness ratio of $5,000 per QALY. This is the value for money measure. For every $5,000 you spend, you get 1 QALY in return. Obviously, lower ICERs are better, right? So you would prioritize health technologies that have smaller dollar figures per QALYs. And ministries of health will often have a threshold incremental cost effectiveness ratio that it uses to decide whether a particular health technology is good value for money within this perspective. So that's how that works. How does it work from the societal perspective? Well, as I said, from a societal perspective, the health benefits matter, but the broader socioeconomic benefits matter as well. And I provide you with an enumeration of those broader socioeconomic benefits. So within the societal perspective, remember, within the health payer's perspective, value is basically measured in QALYs. In the societal perspective, you have QALY benefits, but you also have all these other socioeconomic benefits, and you need a common metric of value. So what's typically used is to measure value in monetary terms. So using a societal perspective requires you to measure people's willingness to pay for health and all these other socioeconomic benefits. So how does this work computationally? Imagine that in Malaysia, a taxpayer's willingness to pay per QALY is about $20,000. And imagine also that the health gain from the technology that I described in the previous slide, remember that technology produced a QALY gain of 1.8 QALYs. Let's assume that that 1.8 QALY gain improves productivity, improves macroeconomic outcomes, so GDP actually rises by about $500 per taxpayer. Then the broader socioeconomic benefit from the vaccine, as you can see in the formula, it's the 1.8 QALYs, which you multiply by the $20,000, which is the willingness to pay per QALY. You add to that the $500 GDP benefit, and then you divide that by the cost. You subtract 1, you multiply by 100, and you get a rate of return. In this case, the rate of return per dollar expenditure on the vaccine is 305%. That is a spectacularly good rate of return. The rate of return to the stock market, for example, in the United States is about 10%. The rate of return to primary schooling globally is typically estimated at about 15 to 20%. So if you were to have a health technology with a rate of return of 305%, that would be an excellent investment of public funds. Obviously, high RORs are better. So that's how analytically economic evaluation would work from both types of perspectives. I'd like to give a few comments on these two perspectives. First, the health payer's perspective is the traditional approach that's typically used by health technology agencies and by NITAGs. So for example, the Malaysian HTA evaluation of PCV that was included in the brief, in the materials, in the policy brief we were given, used a health payer's perspective in the sense that the main economic benefit, other than the QALY gains, was reduced treatment costs. But the societal perspective is growing in popularity across the world. For example, the Advisory Committee for Immunization Practices in the US and the WHO's SAGE both advocate the use of a societal perspective. Why would you use the societal perspective? The ultimate justification is as follows. Why would you ignore the socioeconomic benefits when these benefits are valuable to the taxpayers or to the premium payers who ultimately finance the health system and to whom the Malaysian government is ultimately accountable? That is the main justification. Now, using the societal perspective does involve challenges. Two particular challenges worth noting are, first, it does require you to monetize the value of health. And second, it does raise some equity issues. Now, next comment is that both the health payer perspective and the societal perspective can help the Ministry of Health allocate its health budget, although they will provide different answers. But although both perspectives can help the MOH, only the societal perspective can help the MOF and the cabinet, right? The health payer's perspective is completely silent with respect to the relative value of health and all the other socioeconomic values, such as education, productivity, financial risk reduction, poverty reduction, and so forth. Therefore, the health payer's perspective cannot guide the Ministry of Finance or the cabinet decide on whether it's worthwhile to raise the health sector budget at the expense of some non-health sector budget. What this implies is that only the societal perspective can help address the growing affordability issues that are starting to be a concern with vaccines. My view is obviously that the societal perspective is superior, and that both the MOH and ministries of finance and cabinets should adopt some version of the societal perspective. Now, I'd like to talk briefly about the broad socioeconomic benefits of vaccination in general and universal pediatric PCV in particular. Some preliminary remarks regarding these benefits. First, the beneficiaries are not just vaccinated individuals, and they also include their caregivers, their household members, the immediate community through herd effects, and the larger society and economy. Second, I'd like to distinguish between health's intrinsic and its instrumental value. So health has intrinsic value in the sense that health is good in and of itself. And so within the societal perspective, we recognize that intrinsic value by monetizing health at people's willingness to pay for health. The second element of health's value is what's called instrumental value. It produces good socioeconomic consequences. And these socioeconomic consequences can happen at both the micro and the macro level. So in the next slide, I first discuss the micro level socioeconomic benefits of education, of vaccination. So a very important category of micro level economic benefits is education, right? So one benefit here is that you get fewer missed days of school, fewer school absences from temporary disability, right? And so in the case of pneumococcal disease, this is especially relevant with respect to AOM or pneumococcal pneumonia. Also very important is you would get fewer long-term disabilities from IPD, right? There are certain IPD-related disabilities like chronic lung disease, cognitive disability, hearing loss. These serious disabilities can cause children and youth to drop out of school earlier than they otherwise would have. Or even if they stay in school, they have reduced ability to benefit, or they have a reduced ability to learn even while they're in school. Another education impact, and I'll elaborate on this further below, is that vaccines offer some financial risk protection to households. And when households feel more financially secure, it makes spending on continued education more affordable for households. So the financial risk protection that households enjoy from vaccination will also will facilitate increased educational expenditure. After education, we have productivity benefits. Clearly, if you have higher educational attainment, and we've just discussed how vaccination can lead to that, and if we also have reduced long-term disability, then your productivity will be higher, where we might measure productivity in terms of your wage, your hourly wage, or your daily wage, or your weekly or monthly wage. It will also increase your labor supply, meaning the amount of time you're able to offer for production, right? So there will be fewer missed days of work due to temporary disability. And these days of work may be days of work of the vaccinated person. It may be the days of work for the caregiver of that vaccinated person, of the disabled person. When you have herd effects that reduce pneumococcal disease in adults, they will miss fewer work days, and so there will be productivity benefits there. If you prevent long-term disability, you also prevent labor market exits, right? And so you can also delay retirement. And these particular, and keeping people in the labor market and delaying retirement are particularly important in aging societies like Malaysia. Now, as I said earlier, vaccination can also result in financial risk protection. If you don't get pneumococcal disease, you don't incur all the out-of-pocket expenses associated with illness. And you also don't have to forego any earnings from either death or disability, whether that disability is long-term or temporary. So you protect household finances from catastrophic expenditures and from lost earnings. You protect households, you make households more financially secure, and you facilitate investments in education. When you promote household and individual productivity, you promote household earnings and financial security, you will also raise household levels of consumption, levels of leisure, and savings. That leads us straight to the macro level benefits, right? So when you have these benefits at the individual and household level, you start to see benefits at the societal, at the national level. You will have fewer households falling into poverty because of out-of-pocket expenditures and lost earnings. Therefore, you may have an impact on reducing national level poverty rates. You may also have more households rising out of poverty because of higher education and higher lifetime earnings. You may have more fiscal benefits because if people are in the labor market more, and if they're earning and spending more, there'll be more tax revenues from earnings and consumption taxes. There'll be lower disability payments. You can have greater economic growth because through the impact on labor supply, productivity, and savings. You have reduced burdens on employers and corporations from absenteeism and presenteeism. In an aging society like Malaysia, you also have more productive adults and elderly. And when you have more productive working age populations, they're able to support larger dependent populations. And when you have healthier elderly populations, the elderly are less dependent and therefore require less support from the working age population. Now, when we speak about the broad benefits to universal PCV for children, all the micro and macro level benefits from the previous two slides, they apply, but they are magnified by two specific phenomena involving pneumococcal disease. First are the herd effects on the elderly and on adults, right? And so you vaccinate the children, you have reduced incidence of pneumococcal disease in adults, especially those with chronic conditions and the immunocompromised and the elderly. They can stay in the labor market longer. They impose fewer disability burdens on the working age in the population. And so it helps Malaysia cope with the socioeconomic and fiscal burdens of aging populations. It's also magnified by growing concerns about antimicrobial resistance, because the universal PCV vaccination reduces AMR through a direct effect and through an indirect effect. The direct effect exists by reducing the incidence of resistant IPD, right? So you directly reduce the incidence of resistant disease. But you can also indirectly reduce AMR burdens by reducing antibiotic use, right? For example, from AOM or from pneumococcal pneumonia. So direct effects through reducing the incidence of resistant disease, and indirect effects by reducing antibiotic consumption. So my last topic is I'd like to compare the different kinds of perspectives as they apply to Malaysia. So as we saw in our profile packet, the Malaysian HTA evaluated PCV vaccination from a health payer's perspective, meaning to the extent that incorporated economic considerations outside of quality benefits, they were largely tied to averted direct costs. So it was a straight up health payer's perspective. Wu et al., which was also in the briefing packet, had a cost-effectiveness analysis of PCV in Hong Kong. Now, interestingly, it adopts both a health payer's perspective and a societal perspective. But the societal perspective that it adopts is a limited one. The societal perspective costs that it considered were limited to lost market productivity during the hospitalization. So basically due to again, so it's lost market productivity to hospitalization. A full societal perspective analysis would go considerably beyond these categories of benefits, right? So even if we just look at productivity, which was discussed by Wu et al., a full societal perspective would recognize that productivity is also lost from death, from long-term disability, and second, market productivity is important, but non-market productivity is also important. There is a lot of production that happens in households that are done by housewives and by the elderly, which contribute to household well-being, but are not going through the market. This involves housework. This involves caregiving for children, for sick relatives, and for the elderly. This involves contributing to the community in terms of unpaid volunteering. There are also non-productivity related benefits. This includes benefits on consumption, leisure, financial risk protection, and so on. And lastly, a full societal perspective would recognize the intrinsic value of health by valuing it at individuals, or in this case, the taxpayer's willingness to pay for quality benefits. So let me end here. In closing, I'd just like to echo some of the points with which I began. So a few decades ago, say in the 70s and 80s, the economic evaluation of vaccines wasn't really an important topic. Why? Because vaccines back then were so affordable. The value for money was just so obviously strong, it wasn't worth the effort to measure them. But we now live in an age where newer vaccines are more expensive than older vaccines. So affordability issues are now more paramount, and it becomes especially important to scrutinize expensive vaccines for value for money, especially in light of competing health and non-health priorities. When Malaysia needs to do this, I would like to repeat my main message. To make the right decision regarding universal pediatric PCV, Malaysia must consider not just the impacts within the health sector, quality benefits, health payer cost savings, but the broader socioeconomic impacts as well: education, productivity, financial risk protection, consumption, leisure, savings, all the rest of it. Without using a full societal perspective, Malaysia faces the risk of undervaluing and therefore underinvesting in universal pediatric PCV. That's all. Thank you for your time.
Thank you, Dr. Sevilla. We've got maybe one or few questions from the floor. Anyone would like to actually have any questions or comments? Yes, Dr. Safura.
Thank you, Dr. Sevilla. I'm Safura. I think thank you very much for giving us the whole comprehensive approach to looking at the benefits, socioeconomic benefits as well. But do you have something that is more tangible for us probably to appreciate a model that has been calculated? Because to do a social economic analysis, for instance, were there any done before for like how many disabilities cost that has been saved, or leisure consumption that has improved, or reduction of labor exits that you've mentioned? You know, something to appreciate in tangible terms, monetary terms. Is there anything that you can share with us from other countries?
I can give a general answer and a sort of how do I say this? So I am part of a research team that is conducting research on these broader societal and economic benefits of universal pediatric PCV. Unfortunately, the empirical work that we're doing is not yet at the stage where the results are ready to share publicly. And so my brief today was to only discuss in general terms, without providing more precise quantitative empirical estimates on the broader societal benefits of universal pediatric PCV. But like I said, I am part of a team that is actively measuring these benefits and is hoping to produce results in the near future. I'm sorry that I can't provide more detail or more enlightening results on this occasion.
Yeah. Okay, I think probably we will get this data out from within ourselves, you know, trying to actually get the Ringgit Malaysia kind of impact that any health technology assessment. I think we should be coming up with those data within our folds rather than, you know, getting others to advise us on that. I think probably this crowd should probably have some real initiative to actually get our health economies together so that we can actually measure those impacts on us. I think the one that's done by Matas is looking at the traditional way of looking at the cost effectiveness analysis, but I think the societal perspective is also as equally important. Yeah, do we have any further discussion, comments, questions, or whatever from the floor? I think for clinicians or for pathologists, the economic thing is actually a bit more dry in a sense. It is actually out of our, forte in a sense. But it is very important to the policymakers, to those who sign on the dotted line. So the dollars and cents is actually the more important aspect that they need to consider. Whether is it worthwhile to actually provide the funding for us? So I think we should probably be well aware of how to measure the impact of our intervention in the dollars and cents. So that we can speak on the same kind of wavelength with our health minister and the finance minister. Okay? None? No question? You guys are hypoglycemic? No more? Okay, I think, is there any message, words of wisdom from across the Atlantic or the Pacific, if you go westwards, Dr. P. Sevilla, for us in Malaysia, as we actually proceed on trying to actually have this program in Malaysia?
So if by this point in my presentation I have failed to convey my main message, then my whole presentation has been a failure. My goal was to start and end with the exact same theme. And so my parting words are exactly the same message, that in order for Malaysia to make the correct spending decisions, investment decisions regarding universal pediatric PCV 13, it has to go beyond an assessment of the impact of the vaccination on health sector outcomes. And it must take seriously measuring or valuing its impact in terms of the broader socioeconomic outcomes of the sort that I've discussed. And it has to communicate that value proposition to the Ministry of Finance and to the Cabinet.
Yeah, okay. I think that's the other way that, what is one of our role is actually being advocates for our patients and the wider community, so that we need to actually provide the voice for the people on the ground so that our policymakers can actually decide on this important decision. I think we take note of your message, then we hope, we certainly can draw a lot of advice from your presentation. Yeah, looking at just not dollars and cents itself, but trying to actually monetize the broader social perspective of our health program. So that is also important, and trying to communicate this to our cabinet and to our finance minister, so that we can actually have more health dollars spent for our budget. Yeah, in our budget. Okay, I think if there's no other further question, I think the last thing we would do is probably to thank Dr. Sevilla from all over the way from America in the usual manner. Can we give him a big hand? Thank you so much, Dr. Sevilla.
Thank you very much. Thank you for inviting me.